Dr. Stevenson has contributed greatly to the understanding of the optimal evaluation and management of patients with heart failure. And I'm thrilled to say I've been able to work with Dr. Stevenson over my entire career, including the fact that she was my heart failure teacher when I was an intern in medicine. Lynne, thank you for joining us today.
It's a pleasure to be with you, Jim.
Thank you so much. So what I'd like to do is think a little bit about where we've been and where we're going in heart failure care. And you've done so much over the years, and I'm sure you are well positioned to help us understand where things are heading. So let me give you a 10,000-foot view question, which is, where do you think heart failure will be in the next 10 years?
Well, we've made amazing progress in coming up with therapies that have changed the landscape for heart failure and really improved prognosis. I think where we're heading, though, is trying to understand that each patient is different, and how are we going to individualize from these many effective therapies for each patient. We know the therapies that are effective, but how do we best combine those in patients who have different profiles?
So you use the word profile, and one of the things that the folks listening may or may not recognize is that the way that we approach patients with heart failure, looking at whether they are wet or dry or cold or warm, was something that you originally described. So this concept of profiling patients is something that clinicians are comfortable with, but it sounds to me like you're talking about making this even more complicated.
And it is more complicated. At the first level, we need to be distinguishing when we talk about the wet or the congested patients between those patients who predominantly have left-sided congestion, who have biventricular congestion, and those who are moving into predominantly right-sided congestion, because they behave very differently. I think another way in which we need to further develop our profiles is recognizing not only the patient who already has clinical disease, but the patient who is at risk for congestion, because I think that is what unifies heart failure across the ejection fraction. Whether it's low ejection fraction, preserved ejection fraction, or mid-range ejection fraction, those patients who are at risk for congestion, I think, are a special population. And in those patients, therapies that help treat or prevent congestion, like the SGLT2 inhibitors, they apply all the way across the spectrum. Whereas I think our specific neurohormonal interventions perhaps have a greater effect on patients who not only are at risk of congestion, but also have ventricular remodeling with decreased systolic function. I think it's very important to recognize that those are different profiles of risk, even if their clinical profile is warm and dry across.
That's really a remarkably clear and compelling answer, and it speaks to the philosophy that you and I have discussed over the years, which is trying to rebrand heart failure to heart success and trying to understand patients in a way that prevents progression to what we refer to as late stage C or stage D heart failure. Do you envision that with better individualization of how we characterize patients, we will differ how we treat them?
Absolutely. And I think one place to look at that is in the stage B or pre-heart failure. Those patients who are not particularly at risk of congestion may need different therapies than those patients who are most likely to manifest their heart failure as congestion. I think we're going to want to treat those differently to prevent the progression of disease. The other thing I think we need to recognize is that as we move into more advanced heart failure, ambulatory heart failure, but still advanced, there's some patients in whom their limitation is solely that they can't get rid of their congestion. Whereas in other patients, they're having significant problems with low cardiac output at the same time as they have congestion. And they may clinically look similar in terms of their symptoms, but we're going to need to come up with different therapies to address that.
So many profound things there, and I want to focus on each individually if possible. Let's start across the spectrum of heart failure and start first with the pre-heart failure or stage B individuals. For years, being a biomarker person, I've looked at individuals with elevated natriuretic peptides who now qualify for stage B classification. And I've known that they've been at high risk for incident heart failure, but it took time for people to get their head around that there might be abnormalities in the way the heart expresses itself that we can't see on echo, for example, but with a blood test we can. This is a really sort of forward-looking question, but even though in clinical trials we get the sense that people with elevated natriuretic peptides, for example, had very large relative risk reductions from being treated with SGLT2 inhibitors, for example. Do you envision that we might start thinking about heart failure prevention in terms of taking folks in stage B and preventing progression to symptoms?
I think this is where we need to be spending a lot of attention. Now that we have therapies that we think can help prevent progression, we really need to find those stage B. On the other hand, I think it's going to be important using exactly the biomarkers that you've studied so well to characterize that risk. We can't be treating everybody out there who has some risk factor with the same combination of 4 therapies. So we really need to understand the risk that each patient faces and to treat that risk. I do think, Jim, that we've been extraordinarily lucky with ACE inhibitors and beta blockers in that they have affected such a wide range of patients. I don't think we're going to see that with all the additive therapies. SGLT2 inhibitors are an exception. I think because congestion is so prevalent, they're going to affect a wide range of patients. But other therapies we have, certainly we don't give CRT to everybody.
No, certainly not.
And we're not going to do MitraClip for everybody. The same way for drugs, I think we need to understand what each patient needs to have added.
Yeah, I think it's important to recognize that in some ways we've gotten lucky with many of the therapies we give in heart failure. Not a single one of them was initially developed for the diagnosis of heart failure, and yet here we are with some profound effects. You said something about stage B that I think is critically important to segue to the point that I wanted to build on that you touched on regarding later stage C or early D. First of all, we often find ourselves as clinicians, myself included, wishing that we had sent a patient for consideration of advanced heart failure treatments or device implantation sooner. You know, we look back and say, gosh, we could see that their trajectory was changing, and yet we missed the opportunity possibly. And we often treat our patients, particularly in stage C, with, as you said, the same 4 drugs. Will that change? Do you envision that it will always be the 4 pillars, or will there be opportunities to intervene with device therapies, for example, at a different time than we might in another patient?
Well, I think when we look at that question, we have to decide what do we mean by the late stage C or pre-stage D, if you will. If it's somebody who is basically going into cardiorenal, I think that we may be able to prevent by adjusting therapies earlier. And I'm very hopeful that SGLT2 inhibitors will help preserve renal function and perhaps prevent or delay cardiorenal disease. On the other hand, I think we need to recognize when someone is slipping into a borderline low output state, that's not the time to be up-titrating beta blockers. We need to be very careful about this concept that everybody needs to be on all the drugs, but particularly they have to all be on target doses.
Right.
We don't have many patients on target doses at any stage of heart failure.
Right.
I want to make sure that we perhaps soften this accusatory tone that is often taken towards clinicians, and we're blamed for having inertia, for not driving all these drugs to the max. But I think we need to recognize that physicians are pretty wise, and when they've followed patients for quite a while, there's often a reason why somebody isn't on a higher dose of a drug. And I want to make sure that we learn about individual patient profiles and how to optimize their drugs, not to aim for a target dose that worked in a trial of patients that aren't like our patients.
That's a really critically important point. We see this in our guideline-directed medical therapy clinic where we are treating individuals who are stage C, but they're earlier than the patients that you see in the transplant program. We get our patient referrals from general cardiology, medicine, etc. And these patients, not surprisingly, look more like the clinical trial type patients because they're not as advanced and they do tolerate the bigger doses. And yet, when you think about the relative and absolute risk reductions, although we're getting good relative risk reductions in these patients, it's the larger absolute risk reductions in the higher risk patients that you see that really can potentially meaningfully derail a patient from crashing and burning, right? You know, we're not expecting many of these earlier stage patients to need transplant anytime soon. So individualizing and recognizing when a patient is heading in a bad direction is very important.
I do want to make another point that I think is often missed. which is that transplant affects about 4,100 people last year. VADs were down to about 3,600. And best estimates that we have, there are probably between 150 and 200,000 patients with pre-stage D or stage D heart failure with low EF. So the idea that everybody is moving towards transplant or VAD, I think, is abandoning a very large group of patients who need to have their therapies adjusted, and transplant and VAD aren't going to be one of them.
And when you say therapies adjusted, can you give the listeners a landscape of what sort of therapies you would think about for those patients?
So when we have somebody who is moving into the borderline low output, I have to look at their beta blockers, frankly. And it may be that I need to decrease the beta blocker a little bit and perhaps use ivabradine to keep their heart rate from going up. We don't have data. This is a data-free zone, but we need to be thinking about it.
You're a clinician, right?
If we have somebody whose GFR is down to 20, I need to think about pulling back the drugs that are inhibiting renal function and preventing me from diuresing that patient. We were hopeful that omecamtiv, and I'm still hopeful that we'll find the group, because there's no question there are patients who need help with inotropy.
Yeah. And rather than utilizing an inotropic agent that might increase the risk for arrhythmia, omecamtiv, at least in the clinical trials, seemed to not be associated with the risk of proarrhythmia, while enhancing the function of these patients. The lowered natriuretic peptide concentrations, they had better outcomes, actually, with an interaction, actually, at baseline with respect to lower EF being the patients who've benefited. And these are the patients you're talking about.
Another thing I think that many people don't realize is that the patients hospitalized with heart failure are not like when I saw you when you were a medical intern.
Right, very different.
Most of those patients are taken care of at home now.
Yeah.
So the people who make it in the hospital, in some cases, have really declared themselves as having some refractory aspects. So we can't be looking necessarily to load them with full doses of therapies that they've been on for a while and, in fact, now may not be tolerating as well.
It's really remarkable how much things have changed and how we as clinicians have had to respond to that change. And when I think about the last 10 years even, and it will continue to evolve, there are newer drugs coming, there are devices, barostimulation, other things that might come onto the landscape for our management strategies for our patients. We're going to have to learn how to individualize care better. I agree with you. And as a biomarker researcher, it makes me pleased to hear you say that, actually.
Well, and one of the things I think we need to do, I hate to move away from simplicity, but I think we're going to need to be looking at each individual's patient biomarkers, particularly in these pre-heart failure stage B, and look for changes in that. So some person who starts out with a BNP of 20, I may need to worry when it's 50.
Yeah.
But that doesn't yet cross a threshold where we would normally necessarily be enthusiastic about vigorous treatment. So I think we need to define people with their own baselines and respond to that, as opposed to having absolute thresholds that apply across weight and age and gender.
Exactly. Everyone has covariates that will influence what the numbers are. And interpreting one person's natriuretic peptide value may differ widely compared to someone else. A person with a BMI of 40 versus a BMI of 20, for example.
For instance, I don't know if you may know how much we rely on BNP in the hypertrophs.
Yeah. No, I'm very aware. Yeah.
For example, I don't know what the normal should be for a lot of my patients. I just get it and then watch and make sure it doesn't change.
Yes. Yeah. As a biomarker person, clinician, trialist, it has made me really grateful to see the rapid evolution of interest and understanding about the flexibility of these biomarkers and how they may be useful. And the hypertrophic cardiomyopathy patients, for example, under treatment with drugs like mavacamten, reducing gradient, really fascinating. Well, Dr. Stevenson, in the last 30 seconds, I have a question that I ask everyone to one degree or another, to have the listeners understand who you are as a person. And what I've been asking is, what brings you the greatest joy in your work?
Seeing patients who come discouraged with their heart failure, who can then have new hope and tell me 6 months later that they never thought they could feel this good.
Yeah.
And it can be done with medicines. It doesn't always take a transplant.
It doesn't always take a transplant. And with that, I'm going to thank you for joining us, Lynne. It's really been great chatting with you.
It's been really fun, Jim.
Thanks very much.